Welcome, everyone. It is 10 o'clock Mountain Standard Time here in Salt Lake City, Utah. We have a team of people today joining us for the webinar with our new partner to announce our new partnership with Health Roads and an integration with their product SocialRCM. The name of this webinar is The Role of Medicaid Expansion in Housing First, Homeless Prevention, and Addressing Social Determinants of Health. Today, we are joined by three panelists. Um, and in this order, we will have them introduce themselves. Next slide, David, please. David, we have joining us. He's our Vice President of Strategy here at Eccovia. Next, we will be joined by Rajiv Ghosh, CEO and founder of Health Roads. And then we will be joined by Stacy Berta, Manager of Solutions Engineering here at Eccovia. I will hand it off to you folks. David, do you want to introduce yourself?
Yes. Hey, it's great. Thank you for joining today. Really been looking forward to talking about this topic, and it's just excited to have this discussion. I am, as Bryce mentioned, I am David Lewis. I'm VP of Strategy. Been in the health and human services industry for right around 15 years. I'm also the Vice President of the National Human Services Data Consortium. Rajiv.
Well, thank you, David and Bryce, and very good morning or good afternoon if you are in the Eastern time zone. So glad to be here. My name is Rajiv Ghosh. As you see, my smiling profile on the slide here. I'm the founder and CEO of Health Roads. We are a product and consulting company based in California, but we do business nationwide at the moment. And today I am very glad to join David to talk about our newest offering, which is a revenue cycle management product, SocialRCM, and how it can integrate well with ClientTrack and provide value to your operations and your organizations. Thank you.
Thanks, Rajiv. I appreciate that. Great to see so many familiar faces joining us today. I am excited as well to demonstrate some of the components related to the SocialRCM product. Many of you I have had the opportunity to work with in the last over 12 years now, working here at Eccovia, as I've supported agencies as a client success manager, solution engineer, and manager of solution engineering, amongst other roles. Really passionate about identifying and solving problems across the community and serving the communities you serve, and love my job for that and the exciting partnership with Health Roads to continue that effort. I also worked on the other side of the fence in social services for over 8 years before joining Eccovia, and that really started my passion in supporting organizations and communities to solve problems as I worked with an agency that served victims of domestic violence primarily. So really looking forward to the webinar today. Thanks, David.
Thank you, Stacy. All right, so we're going to be covering 4 key areas today. There is certainly anything with Medicaid. There's a lot to discuss, but we're going to keep it pretty high level. We want to talk about what is the Medicaid expansion? What does that look like? How is that expansion supporting enhanced service delivery, collaboration at a community level? Which gets us into the impact on social service organizations. What has this meant? I know, again, Stacy mentioned there we have a lot of our clients working in the homeless services space. I'm sure if you've attended a conference like NHSDC or NEH, you're hearing more and more about the importance of collaboration with the healthcare sector, using Medicaid dollars through Medicaid expansion to support housing first. So we have some models to share today, some examples of communities that are doing just that, which leads us into challenges and barriers. This is certainly can be a complicated and difficult process. It's not just a question of technology. It's a question of process and governance, such as navigating HIPAA or how to collect and organize data to bill Medicaid and manage care plans. And for those of us on the social services side, this could be a very new new concept, but it's something that really is foundational to enabling the evolution of care delivery in a community, which leads us into solutions. We're going to talk through how we've solved for this problem in Client Track in partnership with Health Roads. We'll have a brief demo today of that functionality, and then we're going to close with some Q&A, and hopefully you'll have some questions to ask us. Again, it's a big topic, so looking forward to the discussion today. All right, so we're going to start off with that overview, understanding Medicaid expansion, if I can say the word. And some basic overview of Medicaid expansion. So Medicaid, Medicare are managed by the Centers for Medicare and Medicaid Services. So part of what expansion looks like is enabling what are called waivers under Medicaid. And those waivers, typical bureaucratic fashion, two different types of waivers that we're going to reference today, 1115 waivers and 1915 waivers. Under Medicaid, states have to apply for a waiver that enables that expansion. And currently, as you can see, and especially since around about 2014, many states have opted into this opportunity. And the way states have implemented their Medicaid expansion programming, those waivers that they've submitted, cover everything from expanded eligibility. So that could be new populations that are covered under Medicaid. It could be changes to enrollment or eligibility to make Medicaid more accessible, as well as enhanced benefits and really most impactful, addressing those social determinants of health needs. So part of our presentation today, we're going to touch on what types of services, what eligibility groups, and how are states and most importantly, communities leveraging this new benefit to improve outcomes and to better serve the vulnerable populations in their communities. Rajiv, do you have anything you'd like to add regarding just the overall scope of Medicaid expansion across the United States?
Not at this point, but maybe one couple of data points I can add just to set the whole thing into context, David, just what you just said for the audience here, that Medicaid is the Medicaid spend, just to put some numbers around this. So the Medicaid spend in the United States is a very large number of our national healthcare spending. In fiscal year 2023, it was about $860 billion. And it is growing at a steady rate of about I just wanted to quote the right number, 5.2% steady rate. And according to the Center for Medicare and Medicaid, CMS, this rate is going to continue through 2032. And by 2032, this spend is expected to go to about $1.39 trillion. So you can understand the scope of this Medicaid. And obviously, there are different factors and reasons contributing to it. And there are lots of debates and disputes and conversations that we all hear about. But the fact of the matter is, this has been a steady increase in the spend. And despite all of those conversations and discussions, that trend has continued. And as you can see from this picture, the states have leveraged this spending to expand either their population of care as well as the services that they're rendering, and more leaning into this. So I will stop right there just to make sure that everybody has the context of the
it's a great
opportunity in front of us, all of us here, to serve the people.
Thanks, Rajiv. Yeah, that's good commentary. Yeah, lots of opportunity and a lot of change, and change in a positive direction as far as broadening that access and ensuring that communities are able to leverage additional resources that they might not have had otherwise. And I think certainly for those in the homeless services space, behavioral health space, there's never enough resource to meet the need. And the incorporation of the expanded services and funding that Medicaid expansion offers really can form the foundation of a very robust and smarter social safety net. Looking more specifically at the Medicaid expansion opportunities, we previously mentioned that Medicaid expansion can look a little different in each state. So it could be new populations that are eligible. It can also be waivers and expansion efforts focused on addressing those social determinants of health. And in the healthcare side, they refer to this as health-related social needs. So those are things like rental assistance, housing navigation, medically tailored meals. It's the services that really, and this won't come as a surprise, I think, to any of us, that are intended to be prevention oriented and address those social determinants that are affecting health. And ultimately, in communities where this is adopted and used to enhance that service delivery, communities have reduced overall spending on social services and they have better outcomes. Just out of curiosity, we do have a poll question. Bryce, if you could put that out there just to get a sense of maybe where you're at in your communities on this topic. So if you want to put that out there, Bryce. Another way to, one other consideration, and I should have added on the previous slide, is aside from the waiver programs themselves, some states have adopted further provisions, which are called in lieu of services at the state level, to offer even more expanded services and ways of using their Medicaid funding to enable more effective social service delivery. So places like California, under as part of the CalAIM program, which we're going to talk a little bit about later today. But there's a lot of momentum behind this national movement, a lot of buy-in at the state level. Rajiv, did you have anything additional you wanted to add there?
There are, I think you covered it. We will go into a little bit into that conversation at the later part of the webinar. But I think you covered that. You touched on the main aspects of it. I don't want to add any more.
Sure. Thanks, Rajiv.
Yeah.
All right. So we're going to move along. So I mentioned earlier some examples of those services, and this really is a sample of what is a very exhaustive list if you were to look at all the ways that states are enabling access to broader services and directly paying like social service providers for things like housing deposits, housing tenancy. And this, in many cases, can be the revenue that enables communities to truly pursue housing first, being able to provide those wraparound services that are going to enable long-term housing stability, or if you're, in the medically tailored meal space, is going to further support your service delivery through sustainable, dependable revenue, which can be a real challenge when your primary revenue sources are grant-based and especially competitive grant-based at that. Rajiv, did you have any other comments on the service side? Anything you've seen in your experience working with communities to either implement community care coordination or to improve their access to Medicaid?
Yeah, so a couple of things maybe I wanted to add here is that in our experience, what we have seen is the service providers in the community-based organizations, they are encountering the situations that even though they're providing just social care services, but they are encountering situations when their clients need some sort of other services which are borderline clinical maybe. So we are seeing more and more juxtaposition of services. So the boundaries between, we are just a social care service or a housing service providers, or we are just a behavioral health providers, we are just a meal delivery providers. I think these are getting a lot more blurry. And that is a very interesting development. I mean, that is happening more and more. It's not that it didn't happen before. I mean, obviously, there are hybrid organizations that existed even before, but I'm seeing this is happening more in our experiences, that behavioral healthcare providers are also helping at least doing some housing navigation, or the housing navigation services providing some sort of on-site behavioral healthcare services. So those are the kind of things that are happening. And as those are happening, the access to Medicaid funding, because many of those Medicaid dollars are going into the reimbursement, it is getting more complex. And I think that could be, so sometimes what happens is some of these providers either leave the opportunity to tap into these additional dollars because of the complexity of the process.
Yeah, that's a good call out. And I did want to add, and Rajiv had mentioned, there is a lot of opportunities, and I know a lot of communities are pursuing closer collaborative efforts with the medical clinical services side. And it is, there's a lot of opportunities for that collaboration, including in many communities that have medical respite. That's becoming a national best practice on the homeless services side. And this is a vehicle to support enhanced or expanded service for that population. And there's a lot of other ways in which the expansion funds can support enhanced collaboration between social service and clinical providers. All right, we're gonna transition into a discussion on what does this look like on the ground, the impact on communities. We'll also touch on some of the, which you might have heard of as well, some of the national care models that are dependent or supported through Medicaid expansion. So we're gonna hand it off to Rajiv to talk us through those first 3 bullets, and then I'm gonna discuss what does this look like in terms of federal partnerships, Housing First, and some of the conversations that are occurring nationally.
Thank you, David. And I'm not going to take too much time, but I wanted to highlight a few areas only. And obviously, these are just examples, and there are many, many more examples that could be also shared in the future. But a few things here. One we are deeply associated with, because it's a home state, it's our home ground. It's in Alameda County where we are headquartered. And we were engaged in that particular initiative. Our core piece of our work was to enable Alameda County of Health, the health department there, for them to really act as a community hub, if you will, when the state decided to participate in the 1115 waiver program. Or got that approval rather from the CMS, and then transformed the Medicaid, the Medi-Cal in California into and transformed that into an innovative program called CalAIM. And there was there are 2 areas. One of them is called community support, which is essentially housing services, like housing navigation services, tenancy sustaining, and housing deposit services. There are many more, but the county, the health department decided to support the CBOs who are providing these services to actually tap into the available Medicaid reimbursement model through this program. It required working with the managed care framework and the managed care health plans of the state, which is not easy. And these CBOs were not prepared to work with that. So we enabled with our work, we worked with the county and make sure that they were able to support the CBOs, and slowly that number rose. And over the last couple of years, since it got started in 22, and this number that I'm stating is from June of 24, it's about, as you see, the number is pretty high, $28 million that got, this reimbursement that happened through the community support services, and some medically tailored meal program support services also that got introduced afterwards, but primarily housing services. And along with that, some asthma prevention services that got also added, as you saw in the service list that David shared. And this model of becoming a community hub at the county level is also got attention at the other counties. And now we are seeing that several other counties are actually exploring this or thinking about this. Now, obviously, we are already 2 years in California, at least, going into the third year now of this initial 5-year stretch of this 1115 waiver program. Potentially, there might be an extension of another 5 years. But the thing is, we are seeing more and more interests in kind of getting into this model because CBOs require this kind of a support. So that's one model that we have seen, a community example, if you will. The New York state recently, as part of their MRT, the Medicaid redesign team, that's the MRT, the acronym is for, they approved their Medicaid 1115 waiver program, and they have a budget of about a 7.5 billion over the next 3 years. And again, a lot of this funding is coming from, there's the federal match there, about a $6 billion. But there is a lot of this is going to go through the community organizations, community-based organizations through different kinds of services. Housing is one area where they're going to spend, but there are other areas where behavioral health and SUD services and other kinds of services where this funding is going to get spent. So we are seeing a lot of interest as well, where CBOs are gearing up, warming up, and to this trend, and they are going to participate in this. But again, there are certain barriers, obviously, getting used to the model of managed care and all of that. North Carolina, we are seeing a similar thing. They have a more recent expansion of Medicaid in general, and they have adopted this 1115 waiver program. Lesser budget compared to California or New York, but still $650 million, as you see, over 3 years. And this funding is primarily going towards addressing social determinants of health through this non-medical interventions. And their model essentially is enabling community hub kind of organizations. And so we have in conversations, in discussions with several of those, at least a few of those organizations in North Carolina who are actively working as community hubs, small, medium, large, and working with the CBOs. And there the model is almost the same as California, where they have to work with either an MCP, a managed care framework, or a managed care health plan, or a managed care organization, depending on the structure, and then get paid. But Medicaid is actually 1115 waiver program is actually funding that. So, but the services have been expanded and the populations have been expanded. So we are seeing this model being put into execution, at least in these 3 states, based on our experience. I'll hand it over to David to cover the last bullet. Yeah.
Thanks, Rajiv. And on that point about these community care hubs, I'm sure you've either through different listservs you subscribe to, or just in your journeys, you've encountered some of these models that communities are implementing, such as a community information exchange or a social health information exchange, and just different models that enable social and health service providers to collaborate in support of the clients they're mutually serving. And this is also a major federal priority, and there's several partnerships focused on making it easier for that collaboration from a regulatory standpoint, from a resource standpoint. Organizations like HUD, Health and Human Services, and in particular under Health and Human Services, the Administration for Community Living, are working together to make that process easier. I'm in a federal work group that is focused on adopting or even considering additions to the HMIS data standard that would enable the collection of information useful in billing, and we can expect more guidance and best practices related to that. And that's where Eccovia and Health Roads have spent a lot of time. We're looking to deliver and enable technology to increase the impact in communities, and this is one way that we can do that. However, it's certainly not all easy, and there's a lot to consider for communities that are navigating that process. And certainly it's not just a technology issue, it's a question of governance, roles, processes, convening stakeholders. So there's a lot to consider, and I'm gonna transition it over to Rajiv to talk through just some of those challenges that communities encounter, and then from here, because we want to move into the positive side of this, how is Health Roads and how are Eccovia and Health Roads solving this problem? So Rajiv, do you want to walk us through the challenges that can come up with billing Medicaid?
Sure. And I think a poll has also been sent for the audience to respond to.
Right. Yes, we have another fun poll, keeping it interactive.
Yeah. So please respond to that. Yeah. So let me talk a little bit about, and I don't want to spend too much time. I know you are eager to see the demo of, the main thing for today. So obviously, tapping into a new revenue stream comes with its own set of challenges. And as we know, and then many of the CBOs organizations, they are used to a certain model of funding, and many times it is fund coming from either, let's say it's a HUD fund, HUD provided grants, or many other philanthropic grants, or other kinds of funding streams. When it comes to managed care-based funding, or a managed care organization, or a Medicaid-based funding, these models were created based on the medical world, and the medical world has learned through lived experiences for decades to how to navigate the challenges and barriers. And even today, they struggle. And then if you look at news and if you look at other things, you know that people complain about things like prior authorizations, that I hate it. You use the term, I hate that. Can it go away? Nobody liked those things, but they know how to navigate. And so when same framework is applied on completely new set of entrants, which are these organizations who are not used to it, it becomes barriers. So that's why, developing internal workflows in case of this billing, or mapping member needs and models of service delivery to the MCP, means managed care plan, health plans requirements. These things are not easy to do. It requires contractual agreements, studying very contracts with the managed care health plans, which many times is cryptic. You don't know what is going to get reimbursed, what services you are expected to deliver, and in what ways. And especially when and we have seen it from our experience that when you have multiple such contracts with multiple health plans, it gets very confusing very, very quickly, because you may be offering services in multiple counties, let's say, as a CBO, if you are a CBO, and you have one county, you have a health plan, and that same health plan has a completely different set of requirements if they're operating in another county where you also provide service. And it gets very confusing, conflicting at times. And then tracking the data of the members who are the managed care or the managed care organization members, even the Medicaid enrollees, their data for ensuring accuracy so that you can bill properly. That itself is not easy. And then if you don't do it right, then your claims will not get billed, not get paid correctly. And even if it gets paid, it might take 6 months to get paid. So your revenue cycle gets affected. And the last but not the least, that understanding this whole process, that what happened? I generated a claim, I submitted. What happened? Did it disappear in a black hole? Well, there is a process like appeals. There is a process like grievances. There is a process, all of these things that the medical world has learned through decades of experience. And suddenly this revenue stream open up, but it is expected that the same process these organizations will have to learn in a matter of few months. That is almost impossible expectations. So I think with that said, let's move on to the demo, and then we'll come back and try to see how we can bridge it.
Yeah, thank you, Rajiv. And you bring up some really good points there, and I'm going to hand it off here to Stacy to walk us through how we're solving for that in Client Track. And at Eccovia, really want to ensure, again, that the solutions we're delivering are impactful and that they're reducing that administrative overhead, streamlining workflows, just making it easier for organizations to focus on the clients and deliver those services. And so our solution, is really focused on automation and streamlining those difficult processes. Stacy, I'm going to go ahead and I'll turn it off to you.
Thank you, David. As we jump into Client Track, I'll point out that the service data that you and your organization, your users currently track in Client Track will support that billing. You do not need to do anything different because of that partnership and the capabilities between Client Track and the SocialRCM product. I am in a generic Client Track workgroup on an existing client, Angie, that we have provided a wide range of services to over the years, because so many of you leverage variation of the Client Track platform. This gives you a general view of the system, and you can see Angie's participated across the board in this existing client record. These existing services can be billed using Client Track SocialRCM components, and that applies to the existing data that is tracked on those services by your individual users. Your administrator can use the service setup to identify which of those services are billable in alignment with that expansion and those health-related social needs that apply. If I navigate to my home workspace as an admin level user, I have access to setup data components, and that is set up directly on the individual service codes that apply to your billing scenario. That allows me to edit those service codes as an administrator and set that billing service identifier to recognize that this, in fact, is a billable service within that model. This makes that data visible and accessible to the users in the SocialRCM workgroup, enabling access to see and manage those billing services within the system. My billing services search gives me that ability to dive in to those billing services in the system. This allows me to search by date range, as well as a wide range of other filters, whether it's individual billable services, the specific claim status for the services, as well as individual clients to see the services over time for an individual. If I filter down into my billable services that have not been submitted for claim status and hit search, it'll identify and display all of those particular services that need to be billed, enabling the applicable users to view and manage those billing services, allowing me to edit if anything needs to be corrected or select and work with that client, allowing me to review and manage that information. I also have the ability to export these. So these have not been submitted, and I'm now ready to submit my billing on my regular schedule. I have the option to export those claim file data utilizing the CSV export function within Client Track. This will prompt the applicable parameters to be set and identified to make sure those billing services are processed and managed through SocialRCM. For those of you who use Client Track CSV exports now, one key difference in this process is it does not require download and manual actions. That file is automatically processed through SocialRCM as an integrated solution to enable the SocialRCM business rules engine to generate the claims and electronically submit the 837 claim file. The claim status, as those claims are submitted and managed, is updated and visible directly in Client Track, allowing visibility into those that are accepted, paid or denied, allowing that to be accessible directly within ClientTrack. I can see if I refresh my search to view those paid claim status, it's going to show those identified paid claims. We can see how much overall was submitted and paid, allowing us to take a look at those particular services that have been paid. As such, I can filter into denied claims, identify if there are any that have been denied, and review those components. If I need more information on those denied claims, I have direct visibility on that service itself to review and see the claim status and related claimed data, allowing me to see that in this case, this was one of those services that required authorization, and there was no service authorization, allowing us to take action, identify, and provide that particular data point so that we can continue to provide those services and obtain that reimbursement for those services that are being provided. This information is then fully accessible through ClientTrack for analytics and reporting, including some sample dashboards I'll demonstrate today, showing that access to those meaningful data points, allowing us to view and see charts and graphs, paid claims, services, and allowing us to drill in and report on that data in those meaningful tools within ClientTrack, including Reports, Data Explorer. And you can see an example here where we've grouped critical claim data by payer and service categories, allowing us to quickly analyze and see totals and information and drill down into individual records to verify and work through that data, making all of that claims information easy to process and see and manage directly within ClientTrack. Before I conclude my demo, David, Rajib, anything in particular you want to add to the items we've shown today?
I think you did a fantastic job, Stacy. I don't have anything, but maybe Rajib, do you have anything you'd like to add?
No, I think I second your comment there. You did a fantastic job, and I think the simplicity. I just wanted to underscore this, that what we wanted to showcase in this demo is the simplicity of the solution. There is a lot going on behind the scene that you don't see, and you don't need to see. I think that's the message here that we want to deliver. That you don't have to leave your system. You don't have to know the complexities. All you need to know that my services are, we know those are billable, and I just wanted to make sure that they reach the right place and get paid.
Yeah, I think that's a good point, and we also need to, and I know we think about this a lot at Eccovia, is a lot of us here come from the social or health services sector. We've done the work, and there's a bit of a crisis in terms of how much data caseworkers, program managers are expected to collect, and how many different platforms they're expected to interact with. Wherever possible, we need to try to streamline processes. And this is one of those ways that we feel is most impactful, because we're going to be able to make this process easier, deliver new revenue into a community that will strengthen that service delivery without burdening caseworkers, program managers, and so on with additional process. So with that, I'm going to go ahead and transition us back to our PowerPoint. Thank you again, Stacy. That was fantastic. Now we're going to talk through, just in the interest of like, what as a community, what does this path look like? What is the journey towards fully accessing the benefits available through Medicaid expansion? And certainly it can be a complicated process. You don't have to do it alone. Eccovia and Health Roads are here to work with you through that journey. And Rajib's going to quickly cover, just at a high level, the 5 steps, as we like to refer to it, to revenue. And with that, Rajib, if you wanted to walk us through those 5 steps.
Yeah, absolutely. And again, this is going to be a very, very high level overview and a quick one as well. If you want to know more or want us to cover some other things, we'll be happy to do so, maybe in a future blog post or something on Eccovia as well. So I think, as you see, the first step is that if you are new to this paradigm of Medicaid and the Medicaid 1115 waiver, 1915 waiver programs, first step is obviously building the awareness. And I think this is the first step that we are doing today through this webinar, is to provide that information. If you want to know more, you can, obviously you have resources, or we can also provide resources if you want us to help. The second thing is, once you know, if you are in a state and you have figured out that, yes, these are the programs that are funded and reimbursed, these are the services. The next step is that kind of mapping or analyzing your existing capabilities to that funding stream, just to make sure that, do you have capacity? Are your services map exactly to the funding that the state, the Medicaid, the waiver program or the Medicaid reimbursement is actually offering? And if so, we recommend that we can do a sort of a financial pro forma to really understand that, well, how much effort, how much staff capacity, staff time will be spent, and what is our revenue potential for that. And then again, that is something we also, from HealthRoad standpoint, we also help our clients to come to terms with that if they're not able to do it internally. The next thing is the contract procurement. This is the vehicle through which the money is going to come. And again, it varies from state to state. Some states, you can do a direct contract with the state Medicaid. Sometimes there is a requirement that only, like California or New York or other or North Carolina example, you have to work with a managed care health plan. In that case, you have to outreach to a managed care health plan, show your capacity, your existing, other infrastructure, to make sure that you get a contract. And that contract, we talked about it a little bit, could be complex. We oftentimes also try to help our clients and customers to sometimes navigate that space as well. But that's the step that is important to have. And then you have to start outreach, the strategies that, well, now the question is, we will be doing the services. And so what is going to be the process? Is there a prior authorization requirement that for every service I need to do a referral and you need to approve it, and then I can do it? So what is the process? What is the workflow for that? We can also support that. We are working with Eccovia to build some sort of that model too in the future. That's again, we're not going to too much into that today, but that's something we are also thinking and working towards, that if you wanted to have that support, we can also build it out for you, that you need to submit a referral and you need to get a referral back, approval back, and tie it back with your claims so that your health plan knows that they have approved this. So that's something, those are the kind of workflow mapping and outreach strategies. How do you outreach to your clients to provide those services? So those are the kind of things that you need to think through. And the last but not the least, if you are not a hybrid organization, the claim submissions electronically requires that you have a National Provider Index or NPI number. And if you don't have that, it's not a complex process. We also guide and help our customers to get it. I mean, again, sometimes it may seem like it's overwhelming. It's actually not. It's a step-by-step process, and it actually take about 10 days, 10 to 15 days sometimes to get a NPI from your submission to get a number. And once you have a number, you are good to go. You have your tax ID, you have an NPI. You are now ready to submit claims to your whoever, the managed care entity, or maybe to the Medicaid to get your reimbursements. So these are like a 5-step process to revenue, as we say, 5 steps to revenue, from understanding what is possible, from being aware of it, and then finally going into actual submission and receiving your payments.
Thank you, Rajiv. That's great. Very helpful, and we know it can be a process, and we're there to support you on both the navigating the process itself and certainly on the technology side. So with that, we want to get into questions you may have. I believe I saw a couple in the chat. Bryce, did I see that correctly? Do we have some questions we can address?
Yes, Kurt August is asking, how can a community-based behavioral health or substance use disorder program provider leverage the 1115 waiver program?
That's a great question. I'm going to defer to Rajib on that one.
Yeah, so depending on your state, there are many states have 1115 waivers, like, for example, Minnesota or Texas, and even California. There are several substance use and behavioral health services are 1115 waiver reimbursable, several of these tasks. So, and we are already working with several organizations who are getting paid for their services. So it is entirely possible. And all we need to do is getting engaged. If you are interested, to get engaged. So on the SocialRCM side, you saw our product, but we also have a consulting wing. And that's something we do because we feel that our customers need both sides, because sometimes they're new to this. As I try to explain, there are a lot of unknowns, a lot of bureaucracies, if you will, to overcome. And sometimes it could be overwhelming because their mission is to deliver care to the vulnerable communities, not to navigate bureaucracies. And so therefore, they need help at times, and with some experts who have lived those bureaucracies. Because my background is I have worked in the community-based organizations in the medical side for many years before going into the human services side. So I kind of bridged that gap. So my team and my folks, they also have done that. So that's why we understand these sides, both sides well. So we, organization like us can always help. And then you have Eccovia's support as well. So we can do it in that way.
Thanks, Rajib. Yeah, that's a good call out. And certainly, at Eccovia, we're, looking forward ahead, seeing, what does modern case management look like? Increasingly, it's going to be a lot of this, like the integrations that support smarter case management delivery and a healthier social safety net, a more integrated social safety net. So, on questions of governance or how to navigate privacy or capacity building, these are all areas that we can advise, and certainly, reach out with any questions you may have after this call today. Certainly want to continue that discussion. Bryce, is there some other questions in the chat?
No questions in the chat right now, but we did have some questions that people have sent us
Yes,
privately.
true.
One of them is, how many managed care plans can SocialRCM integrate with?
And we do get that question a lot. Yeah. Do you know that off the top of your head, Rajib?
Yeah, sure. I mean, we have no limits on that. And I think that's something, we can work with any number of managed care health plans as our customer will need to work with. Because sometimes it could be just one, sometimes it could be 7, 8, 10, depending on the region, depending on the geography that they're operating.
Yeah, that's a good call out. And I know that complexity is going to range from community to community. So it really is situational.
Good. The next question is a national provider identification number, or NPI, needed to implement SocialRCM? And what if we don't have one? Can HealthRoads help with that?
Yeah, if I can jump right in there,
Please.
David. Yeah. So I think, sure, give me the cutting to the chase here with to the last part of the question. Yes, we can help. And coming to the first part of the question, as I tried to explain in the slide before, any kind of a claims processing requires an NPI number. And the reason for that is, this whole claims thing in the way the managed care is created, is essentially created around the medical services or the medical care. And everybody is a provider. And so therefore, everyone has a NPI, it's a provider index. So all IT systems and all processes, they work with that. So yes, the answer is yes, that a provider needs to have that, but it doesn't have to be a provider. It could be at an organizational level too. So you can always bill not by provider, but by organizations. And we have done that. And Alameda County is a great example of that, where we have implemented solution where it was billed at a health department level and not at the individual CBO level or even at a individual provider level. And that's the expected thing. Because if you are a housing services CBO, you are not billing under any particular housing navigator. You are billing under your agency name. That's how it is.
And just to piggyback off that, Rajib, so if we're considering like a community care model, like a COC, a continuum of care, you may want to, as a COC, explore, maybe that's the HMIS lead or the COC lead that is acquiring that number and using, extending that ability to bill for any CBO participating in your client track implementation, so that you're not having to worry about every individual organization pursuing that. So there is ways in which that step can be made easier, and certainly for efficiency's sake and to again enhance that collaboration across the community, the more COC participating agencies that are able to access the Medicaid expansion benefits, the more revenue and the healthier the funding model will be in the community, and they don't all need to individually have that NPI.
Yeah, you're right. And again, I don't want anybody in this audience to have this takeaway that, oh, that is a barrier or that's a big thing. It's actually not to get an NPI number, because it's a very step-by-step process. It's not a very overwhelming thing or anything like that. So please don't go back with this notion that, well, I don't think we can do this kind of a thing, because you can.
Sure.
Yeah,
good call out. What else we got, Bryce?
Yeah, next question. How is SocialRCM different from what I can get from my EHR or clearinghouse?
Well, I want to say a few things first, Rajiv,
Sure,
on that point, because it's something I've touched on a couple times throughout the presentation is, we were very intentional in forming the relationship with Health Roads and in the type of solution that we wanted to integrate. And, one way that this is one very distinct way that this would be different is that we're able to support all of this through one platform, through that integration. In communities that are engaging in access to Medicaid expansion, they're largely having to go through multiple portals, maybe with different payers. They're having to enter the same data over and over again. It's prone to error. As part of the RCM solution, we're able to verify eligibility. We're able to look for data quality issues in claim submission. And it's also able to look 90 days back to see, are there other billable services that got missed? So it's not just the automation and the integration, it's the support we're able to provide to ensure that every possible dollar that can flow into the community is. Did you have anything to add on with that, Rajib?
Yeah, I wanted to add a couple of things here, is that we also hear these things, with some of our initial conversation. We heard that, oh yeah, I can do this. I mean, I have a clearinghouse, I can do this. And, as I said, I came from medical side at some point, and obviously with the electronic health record, they were able to submit it to a clearinghouse. And I know how the experience over there is. So when we started building SocialRCM, we avoided the pitfalls, we avoided the issues of that very intentionally and carefully, because the challenge over there is that as long as you understand, as long as everything is straightforward and you have a managed care plan or a contract, or we have been doing that for years, and everything is straightforward, that model works. The problem with this 1115 waivers and other thing is that these things are in a state of flux pretty much all the time. And why is that? Because the state regulations and state policies change more frequently on these programs. Because remember, these things are positioned as a innovation program. That means the state has a potential of innovating as they go. And that is how it is. These programs are created. These funding streams are created. So as they hear issues, as they hear challenges, they change certain things, they change policies, and those things come down in terms of billing requirements or authorization requirements. Sometimes they waive things, sometimes they add things. No clearinghouse that are in the medical world will ever do that, ever. They are national players catering to medical industry. They will never ever touch their code or their systems to do that. So that's the major pitfall of that model. And that's why SocialRCM is designed. And we also realized that that model works when you have 10 billers sitting there and that's their job all day. That they are just entering billing codes, submitting, following up, large medical practices, So that doesn't work because you don't have 10 billers sitting in your office all day, doing all those things. So that's not the way the CBOs work. So that's why we did a wraparound service around our product so that our folks can handhold at times, resolve issues, provide guidance, work with managed care health plans if need be, so that you get your money, which you deserve to get, and legit money, you get it on time so that your program can continue without any interruptions.
Good. Thank you, Rajiv. And I believe we got another question in there. And I'm going to actually defer to Stacy on this one. My assumption is yes, like you'd be able to enter, because it's fundamentally not changing anything about the process a caseworker would follow. They're still entering the same services, doing everything the same. So ClientTrack Mobile on a tablet or phone, we would be able to support that as well.
Yeah, to be clear, the question was, can the interface work with mobile?
Yes.
Yeah, ClientTrack is mobilely responsive and does enable that access. So from users entering those services to triggering the billing export, all can be managed from those devices in mobile view as well.
Thank you for that. Yeah, that is a great question. We are coming up on time. We'll go ahead. I think, do we have any other questions that we can quickly answer, Bryce? Or
just one last quick one,
okay.
I think. How do we correct claims if there are errors?
Oh, yeah, that's going to be Rajiv, please.
Yeah, so there are a couple of ways, and one way is that's one thing that we always do. If there are issues, you will see those issues on your interface on ClientTrack. Because that's a back and forth going between SocialRCM and ClientTrack. So you can always go back and change your service records. Like, for example, you entered something and we flagged it that, this is incorrect. This doesn't match. For example, a date of birth that you have entered doesn't match with when we do an eligibility check, the result that came back, we found that date of birth and this date of birth doesn't match. And so we flag that because we don't know which one is right. And so you may have to go back and change it on ClientTrack and resubmit that. And so that's another thing. We always do that, and you can then resubmit, and then that resubmissions get processed. So that's how it works. So we get an error report of everything that we do. And even when errors come back, if at all, from the health plans, if they reject something saying, oh, this is in error, that also gets reconciled. We try to correct anything that we might be able to do in the system, but if not, we feed it back to you through ClientTrack, and then you can make those adjustments if needed, or you can seek our help, and then we can help. I mean, SocialRCM side, we can help health roads to resolve some of that, and come through the same help desk process that you have with Eccovia, but then we can be behind the scene to do that. And then you can make those adjustments and we can reprocess it. That's how it
Right.
will run.
Thank you, Rajib. And I think with that, we are at time. Again, I just really appreciate everybody taking time out of their busy days to join us for this discussion. And please, again, reach out if you're interested in furthering the discussion, if you have questions about how your community can access this benefit. And with that, I'll just wish you a fabulous rest of your week. Thanks again.
Thank you.
Thank you, David, Rajib, and Stacy. Just some final notes. We will be sending out a recording with the slides and the answers to your questions from the chat, and as well as the private questions that we had as well. So expect that within the next couple of days. Thank you, everybody.
Bye, everyone.